how can we say things? How can we use our voices for good?
Good morning and welcome to episode 2 of season 4 of Recipe for Success. I have a really exciting guest this morning, Paula Muto. I hope I pronounced your last name correctly, Paula. It's a last name like mine that gets butchered all the time, so I usually like to check.
Muto is fine.
How do you say it?
I say Muto. I like the Latin and Italian in me.
Okay, just wanted to double check and make sure I got that right. Paula and I actually quote unquote met on another podcast webinar about women's breast health, which was a very fascinating. And I was so intrigued by some of her comments. I'm like, I think I need to have you on our podcast as well. So I'm very excited to have you here this morning. Hang on a second. I'm just noticing. Okay, there we go. All the little things of getting back into the swing of a new season, getting all those details worked out. So, Paula is very accomplished. I mean, I felt a little embarrassed when I read her resume. I'm like, I must be a real slacker. She is not only a practicing vascular and general surgeon in a solo practice, she's the owner of Muto Vein Clinic, or Vein Center, and the founder of UBERDOC. UBERDOC is kind of what we're focusing on today, but of course, we are always excited to talk about all of the things that you do. So I would love for you to tell our audience a little bit about yourself and how you got where you are today.
Oh, that's great. Well, thank you for having me, Nancy, and happy Valentine's Day.
Happy Valentine's Day. I'm wearing red in honor of it.
Parts and pink. So basically, I am I'm a surgeon from a whole family of surgeons. My dad was a great surgeon. I'm married to a surgeon. My brother's a surgeon. 2 uncles, all in Massachusetts for a collective century. So you kind of say it's the family business. And so I kind of came into, I love medicine. Again, it's part of my blood. And I think that, so I sort of started this journey as a practicing physician on the front lines, a woman surgeon, and in a sort of poor community next to an affluent community, so in the state of Massachusetts, which went through many changes, including, Romney Care to Obamacare to what we're in now. And so I sort of paid attention to what was going around me and the struggles that my patients were having. And I think it's really hard as a physician today to, and that's why there's so much moral injury, right? They talked about it just today, being able to know what you want to do for your patients, you care about your patients, and you see so many obstacles in the way. And I said, well, what can I do to take away those obstacles other than take out their gallbladder, fix their vein, diagnose their breast cancer, check their carotid? What else can I do to, that's just not enough in this world right now when they can't afford their medications, they don't know where to go, that nobody answers the phone, and they can't talk to their primary. So I thought, well, maybe I could try to fix it. And that's what inspired me to start this crazy journey for the last 8 years, becoming the head of a tech startup.
I love it. It's really interesting. I think I just lost my sound. Can you hear me?
I can.
Okay, well, good. As long as you can hear me, we're good. I had a hip replacement in December, and it's really the first time I've been an active participant in the healthcare system. And I was a little bit shocked, honestly, as far as the disconnect between the providers and the patients. I hate to use the word provider. Let's say the physicians, the caregivers, and patients. They have a job to do, which is great, but they're oh gosh, I'm trying to say this as politely as I can.
So I'll finish your sentence. The workflows are not empathetic, physician nursing driven.
Yes, correct.
The workflows have been corporatized, sort of like managed by somebody who, like, it's an assembly line that you can actually, create, make patients sort of follow the same path, and so that it comes out to a series of billable events.
Yes. And the work was good, but the care was not, if you know what I'm saying.
I know
there.
Exactly what you're saying. Somebody was just saying about, this trauma activation where you have like a room filled with people and everyone has a title and a role. And it's like all these people caring, but no one really cares.
Yes. Yes.
And you see that all the time with all sorts of treatment now. Like, I guess when you deliver a baby, it's the same thing. There's like 25 people in the room. And really it's your nurse that's by your side and your doctor that does the delivery that are the key people, and your family, of course. So we have this sort of like conflated type of healthcare that is a lot of extra steps, a lot of impersonal, and a lot of unnecessary, that's costly and billable. And I think that technology, you had your hip replacement, did they send you home the same day?
Oh, well, they wanted to, but I had an adverse reaction to the anesthesia, so I ended up spending the night. But it was interesting because the nurse practitioner, of course, not my surgeon, came in the next morning. She looked at me and she said, "How are you doing?" I said, "I'm doing great this morning." And she said, "See, you could have gone home last night," and walked out of the room.
Okay, so that's lovely.
I mean, I was dumbfounded that someone would say that.
Because again, we're schooling people in insurance protocols, and you fell outside the regimen, and they have to have an excuse for it. It's the one thing I rail against the system about is that we are, medicine is not it's a service industry. It's not a commodity. But when you turn a hip replacement into a commodity, this is what happens. Now you are a red line on their books because you spent a night, you utilized more than they anticipated. Right. But it happens. Adverse reactions happen. There's some people that can go home and some people can't. And the problem is when you generalize all this treatment based on a business model, not based on clinical, you will send people home who will have a great result because they have a family, they live on a 1 floor, they may be in assisted living, and then you'll send another patient home who's in a 6th floor walk-up, and you wonder why they're back in the emergency room 2 days later, with problems. So medicine is not a commodity. And it has to be controlled by the people who are trained to do it. We have relinquished that control at this point.
Yeah, I would agree with that completely. One of the things that, as per usual, I'm going off script, so just so you know this about me. One of the things that I've been discussing with some of my peers lately is we have this system, and there was a lot of people in the consulting industry, the supporting industry, people like yourself, people that are doing direct primary care, that are providing direct contracting services. And for a while, everybody was railing against the insurance companies. And lately, the conversation has shifted to just let's ignore them and let's build a parallel system which can provide a better care and better results. And pretty soon, everyone's going to want to move over here. And I think that approach is I just think it's smarter. I think we show them what we can do.
If we do it right.
If we do it right.
Just creating another parallel line that looks awfully like the other one.
We don't want to do
that. And so this is where it comes to the power of the patient. See, 10 years ago, even 5 years ago, the thought of sending you home would never be in.
Of course.
They would automatically admit you, put you on a pain pump until you were throwing up, send you home on expensive antiemetics as well as pain medicine, right? I mean, that was sort of the way. And now, it's like, okay, now we're going to, be able to send you home and your outcome is going to be better the sooner you go home. There's no question for most people. So technology has literally shifted the way we take care of patients. And in the healthcare system, we have ignored technology. In fact, we work against it. Many times the business model looks better if you keep your patient longer, or if you do extra tests. It's like, well, but technology lets us do it better, faster, cheaper. But that sometimes flies in the face of a business model that's trying to, the single biggest driver, for example, of a hospital, isn't to send all their patients home. It's to occupy the beds. In fact, occupy the beds, super occupy, so that you have wait times in the ER, because that's very lucrative for a hospital. Anything is lucrative in a hospital anymore. We can talk about why that is, but the point is it's almost like the number of beds dictate the amount of patients you admit. And it's so we have really devolved. We're not about patient-doctor relationship, and I think doctors try so hard to connect with their patients and do a good job, and they do. It's just we're handcuffed at every turn.
I don't believe there's any ill intent by healthcare providers at all. I don't think doctors, nurses, I think there's no ill intent. So when I talk about this, it's because they're stuck in this corporate cog of a system, and they don't even really have an opportunity to connect in a meaningful way with the patient. The patient doesn't feel comforted or safe because there's not enough information. And when the patient speaks up, for an example, to say, like in my case, I'm like, I don't want another pain pill. They were literally shoving them down. They're like, nope, you need to have another one. It's time.
That's what the protocol says.
And I'm like, I don't need another one. I don't want to take another painkiller. And I like, they're going to shove it in my IV. I mean, it's.
So part of this is really been in the last, 15 years with, the whole, one of the things about the Affordable Care Act is that it removed physician ownership. It just
Correct.
slid that in there. Doctors really shouldn't be working for corporations.
No.
We should always put your welfare ahead of the stockholders. Right now, I train residents, and I feel like they don't even understand anymore why they do something. Why are you ordering that? It's because some insurance protocol dictated it, not necessarily because it came out of studies. And even we can argue about studies nowadays, like that people get, things get published that with no peer review even.
I know.
All this time. So we're throwing things sort of at the wall because it's corporations are dictating this. I think the patients have to demand more. And I think the physicians have to be freed. I think that you've got to take us out of captivity. And that can happen. Both of those things can happen at the federal level and state level with a few little changes here and there that can sort of allow people more choice. I think fundamentally, the issue I have with the construction of Affordable Care Act is it came with the premise that patients don't know what's best for them. Mm-hmm. I think that the 1960s paternalistic model of medicine that has been long abandoned. And I think that the longer we hold on to that, the more disservice we do to our patients.
One of the most interesting comments I heard when I was going through that whole surgery procedure was, I think I was talking to my anesthesiologist, and they, of course, they go through and verify your information 17 times. And they were like, well, I don't know who your primary care doctor is. And I said, well, this is who it is. And no, actually I do, because he's independent. And I said, he's an independent. He's not with your big healthcare system. And the response I got was, doctors can do that?
No. Oh my gosh. Well, so we again, with the corporatization of all of this, and with the drive to create solutions and software solutions, electronic records, data acquisition, our patient privacy is gone, and yet it's supposed to be protected. So they expect you all to be. What do you mean you're not on Epic? I mean, I work with a major cancer center. It's the only cancer center left because all the independents were swallowed by it. So I won't say it's the Walmart of cancer, because it is that very high. And my brother actually is a G1 oncologist, so it's a very reputable place, very high. Of course. But now it's just a giant business. They just literally turned around and made a deal with another hospital, and so it's like, for me, when I have patients that go over there, I'm like, well, okay, I need to know what your note said. I need to know what the opinion was. It used to be a phone call. It was a fax to the office. It's like, now it's like, no, you get it yourself. Go into Epic. It's like, well, I don't have Epic. It's like, not everybody speaks that language, right? No one has that access. And so then they're like, tough, like literally tough. Well, you should then. Like, if you're not with us, you're against us. It's like, but why? And I could understand it if we had a plethora of doctors. Like, we had so many surgeons and, oh my gosh, everyone's competing for things. We can barely cover our ER, right?
Yeah.
There's like barely. I mean, I can't get in to see myself for 6 months, and it's like remarkable. And you're like, so that's why these models like UBERDOC, like Dr. Dickerson's, green imaging, is repurposing existing inventory and matching them with patients who are willing to take that step outside the equation, and rest assured we will protect you. Not just protect you as physicians, we will protect your wallet.
Yep.
I think that's the biggest fear patients have, is that if I don't pull that insurance card out and I don't follow all the steps, I'm going to go broke.
Yes, that is a very real fear.
Yes.
I hear that every day from my clients, from members of clients. They call up and even as much as filling a prescription without their insurance card, they're like, I can't fill my prescription. And my answer is, yes, you can. You have the prescription. Right? Cash works.
Right.
But I hear that all the time. And so there is a great deal of fear that has been created around our system. Fear for the patients, fear for the providers, fear if I don't go across the street and get my, across the hallway and get my MRI and actually go down the street and pay cash for it, it's not going to work. Something's going to be broken and somehow I'm doing something wrong.
So we've been doing this for a while, and it's not working. I mean,
clearly
intended. Well, depends. If you're
it's working for the insurance companies.
Well, actually, I think it's working. I don't think it's working for private equity, right? Because doctors are going out of business and being snapped up, and my own hospital's under threat of closure from that. So it's, I guess, it's working potentially as intended as a business model. It's failing completely delivering medical care. And we can say it's failing because we went from top 10 in the world to like number 40 or something. Our maternal death rates are some of the highest in the developed nations. It's like we hear you just had a hip replacement, had bad experience, not from again, your hip is working and so forth, but it left you not feeling great about like how you were treated. And it's like, so every single person who touches the healthcare system comes out and gives it an F. Right. And they don't give me an F. They're so grateful, Dr. Muto, that you diagnosed my breast cancer. I mean, they're so grateful, but it's like us against them at this point. The patients and the doctors are actually glued together at this point, and we are like sort of railing against a system. And I should add the nurses into that as well.
Oh, yes.
And it's
nurses.
So I just don't think it's working. We spend 48% of the federal budget on healthcare. 48%. It's not just 10% like they think. It's 48%. We are subsidizing. Insurance companies get 70% of their revenue from taxpayers, from us. So we are actually paying into a system that is already Medicare for all. Let's forget about it. It's like we already pay taxes, and then we go to our employers, and then we pay the premium, and then we pay a deductible and then we have to pay Dr. Muto. I mean, it's like, okay, what this doesn't make sense anymore. I'm spending, there was a study that a low wage worker spends 29% of their wage on health insurance. It's like, what? Then, and as you go up the ladder, it goes to 15%, and then the C level, it's only 3%. That's sort of like garnishing wages, to support what? To support what exactly? So one of my medical assistants at the hospital said, I only pay $34 a month for my health care for my family. It's like, but have you gotten a raise? I mean, are they paying you what you're actually worth per hour? Wouldn't you rather have that in your paycheck? Because how are you really using your healthcare system that much? If you think about it, people are being held hostage over this fear that they're not going to have coverage. And they've used this coverage as a way to retain employees or to pay them less or work fewer hours, right? Yeah, I want to hire you, Nancy, but I can't afford your health insurance. So you're going to be 27.5 hours a week or whatever it is. And so, so I think that's another quick fix. That's an easy fix. They separated having Medicaid coverage from work. I think they need to separate work from healthcare completely, right? Your employer shouldn't have to be obligated. You shouldn't have to be obligated to go to your employer for your healthcare, right? You should be able to have a marketplace where you can find it. I think that was the intention, maybe the Affordable Care Act, but it really didn't turn that way. Employer-based health care is still like, the largest, purchaser of healthcare.
It was intended to do that, and it was intended to provide a marketplace as well for small employers with under 50. That component failed miserably. They never really got it off the ground.
As a business person, I can say that. All right.
Yeah, it failed miserably. And one of the other really big concerns about buying coverage, I mean, there's a lot of ways that employers can do it. They can do ICRAs, they can do QSARAs. There's a lot of things that they can give the money to employees and buy their own care. The problem is individual coverage is pretty terrible, and it's not comparable to what you can get through an employer. So that leaves people in a bind. It's like, okay, well, I guess I'm forced to take that plan through my employer's plan because I don't want this really strict HMO with terrible benefits.
There's a couple of things that are happening now because we know this is dysfunctional, right? And this a major disruptor in the current workflow. Like these things are in place for sure, but what happens is like if you're not in, if you have one of these plans that is very restrictive, you literally can't get access, you end up
Correct.
highest priced access. You end up in that emergency room with that AFib, or in that emergency, or you get a late stage diagnosis. So then it's like everybody loses, right? Not that the patient isn't the one that has to win or lose, but the economics of it lose. I think that's like a big piece of, these employer health plans. I think the other thing that's you have to realize is that something in the Inflation Reduction Act that said, or the Consolidated Appropriation Act said that, you have to now disclose to your employees, if you're a big employer, what your premium is going to. It's like, oh, what do you mean? It's like, well, we're garnishing wages, right? We're taking this big chunk of money out and we're handing you this shiny card that doesn't cover a whole lot. So they have to tell you, well, what is that money going to? And, broker fees, add-ons, the gym memberships, the telemedicine, all these things that sort of come into play, these what they call point solutions, that sort of add to your bill, but you may not be accessing any one of those. And wouldn't you rather have the cash thank you in your paycheck? And what has happened is that many times these deals have increased the cost of pharmaceuticals. And this is one of the, big issues that now that lawsuit that,
The Johnson & Johnson. Yeah.
Where employees had a class action saying, you're making us pay more for these medications because of the contracts. We trusted you that if I didn't go on my husband's insurance, or I didn't buy insurance on this bad marketplace that doesn't cover much because I have this great job, that insurance was going to guarantee when I pulled out that Blue Cross card, I was going to get a deal on that medication. Then you realize, yeah, you're paying more for it. It's just, I think that this is where the change has to happen. But I think that you can try to fix the employer healthcare marketplace, or you can just decide that it's a choice now. Employers shouldn't have to force coverage on you. You should be able to have choices, but those choices have to be available to you. And a portable catastrophic insurance would be the easiest thing to have.
Well, coming from a family of physicians, I'm sure that the history that, if we dial it back 35, 40 years, maternity didn't even used to be covered by insurance because it was considered to be an elective. I mean, you chose to get, that's how it was. It was not covered under health insurance. Health insurance originally was intended to be catastrophic coverage to protect you from unforeseen financial loss, which was okay because the cost of healthcare was extremely reasonable. You knew what something was going to cost before you did it. And an entire maternity, again, 40 years ago, might have been under $1,000. I mean, it was
absolutely. And, an employer-based health plan didn't even start for any good reason other than a wage freeze that Truman put in during after World War II to
correct
keep workers in the right place. So it's like, it didn't even come about for any really good reason, other than that you needed to, it became a benefit and then we couldn't get away from it. And then it became a subsidized benefit. So no one's going to get away from it now. Right. But I 100% agree. I think that the concept of direct pay we have to re-educate our patients that that's okay, but it is okay because what we do for you today is so much like easier, better, faster, cheaper than we did before. And this is the biggest disconnect I think physicians have with their patients is that, or rather physicians have with the system, is that they keep telling us how expensive we are. But I did cases in my office today. I normally would have taken you to the OR 10 years ago, and it would have cost so much more. That hip replacement that you eventually went home, you would have been 3 to 5 days in the hospital, another week in a rehab. That's all very expensive. That's round the clock nursing. Those are people that are being paid to take care of you with health insurance benefits and all the rest, right? Think about that. Cancer care is probably where the biggest changes occurred. Cancer care is so now like it used to be, in a hospital, and then it was in a cancer center. And now it's like so targeted for you that pill that they make for you is good for you and 3 other people. So by definition, the price of that pill is irrelevant because the drug company's never going to make billions of dollars on it unless they charge you $1 million a pill, which they might if some employer raises their hand and says, I'll pay for that, But honestly, most of the time, it's really the issue is that the perfect cancer drug will never scale. So we're like this. I say this often, that the healthcare system today is holding medical innovation back like a drag chute.
I would agree with you.
And thank God there are so many fabulous innovators out there, many of them physicians who continue to push the envelope. But we're in this sort of broken system where it's not compatible anymore. Like, it's like your phone that just got an upgrade. Your phone has some type of, operating system now. It's no longer compatible with your old phone. And I think that's exactly where we are with our healthcare system. There's no compatibility anymore.
As a tiny step forward in the world of direct pay, you may or may not be aware of, but both Texas and Tennessee have passed bills that now allow somebody, if they are able to direct pay for a lower cost, to submit that to their insurance company, and it counts towards their deductible and maximum out of pocket, which I think it's a brilliant first step.
It's a brilliant first step. It still keeps the insurance company in the equation to raise your rate the following year for utilization. That's the only problem I have with that brilliant first step, is that, yes, from a consumer standpoint, employer standpoint, it makes plenty of sense. It's like, hey, I'm going to use my HSA. I'm going to use it. I'm going to pay out of pocket. I want it counted somewhere.
Right.
But when you count that, that's just like when you dent up your car and you say, I just want this to go against my deductible the next time. Well, guess what? Your premium is going to go up the next year. It is sort of like, a little bit of a sheep in wolf's clothing, or wolf in sheep's clothing. I mean, but it's important for that first step. I 100% agree, to get people to feel more comfortable paying out of pocket. And eventually they're going to be like, well, why do I need to submit it to my insurance if they're not going to pay me back? That's the part that is the coolest, is that the insurance company would actually pay you back.
Right.
That's what has to happen. But now we're going to count that as utilization.
Yeah, I think that the most important piece of that particular legislation is that it's going to make people start thinking a little bit about the cost of their care. Oh, I can actually get the same service less, and I'm not going to be penalized for it. It is
the marketplace to those better options that are out there, and it keeps the insurance company in the equation.
Right.
Which you're not going to cleave insurance from the equation. And I would never tell a person or a patient to say, get rid of your insurance, go bare. That's not at all wise. That's not what we're saying. We're just trying to roll it back to what insurance was intended for.
Exactly.
Unanticipated circumstances. And I think people should be able to bank their health dollar. I mean, I've written about this, called it, do you want to rent an apartment, or do you want to buy a house, right? Do you want to rent? If you rent forever, that money just disappears and you don't build equity. But if you buy a house, you still pay the same amount out of your pocket, but it goes into equity, which you can turn in later on in life. I like to think we should build our own individual health equity.
Yep, I agree.
And there's some people who may have chronic disease that they have to rent their whole life.
Sure.
Other people could bank that and utilize it later when they need it. And I think there's plenty of money in the system to pay for most everybody's care, probably 5 times over.
I'm sure you're right. Okay, so of course, I went right down the rabbit hole and stayed down there, but I invited you on here to talk about your company, UBERDOC, and I would love for you to tell us what it is and how it works.
So UBERDOC is really simple. So UBERDOC is an access to a doctor nearby and available, and you pay a transparent price. You make your own appointment. You go drive to the doctor's office, or there's some doctors available online as well, and you see a specialist. And a specialist, in our definition, are physicians who trained, whether they are a specialty of family practice, to a specialty of pediatrics, to a specialty of neurosurgery, endocrinology, rheumatology, surgery, whatever it is. Those are the doctors that sit on our site. So the idea is it's a fast pass, priority access to the doctor that can solve your problem quickest. So if you think about it now, like if you twist your ankle, you say, what do I do? I could go to the urgent care or the walk-in, where they might do an x-ray, they might do this, they might give you something, and then refer you to your primary, then refer you to a specialist. That whole equation, as we just talked about, is not free. you do whip out that insurance card, but you're paying a copay and a deductible, and you're paying for every step of the way. Plus you're paying in time, and you haven't really gotten your problem solved because you still have to go see the orthopedic. What if you could cross the street and go right into that orthopedic? Well, typically you can't get into that orthopedic very quickly. And you don't want to, if they're in network, you don't want to get a referral, you want an authorization, the Krabby Patty at the front desk will stop you, so wouldn't it be great if you could just say, make the appointment, magic, you show up, magic, they're happy because they've been paid, magic. So it's a win-win for everybody. The patient finds the doctor nearby available, pays a transparent price that they know ahead of time. And the doctor is happy because they're getting a new patient into their system that they don't have to bill and chase down and do collections, and they don't have to pay anything for this, for chasing this money. So it's a cool platform. It was meant for just that purpose, just the first step. The next step could be through insurance. It could be also cash. And as if you needed to get an x-ray, maybe the doctor just does the x-ray because they know they're getting paid for the appointment. They're not going to worry about billing the x-ray, which is what happens often. So it's sort of get to the right doctor right away. And that's what our model is.
I love it. So do you have doctors across all specialties, and are they in all parts of the country?
We do indeed. When I started this, it was 40 doctors with just 6 core surgical specialists. And then people started hearing about us and say, can I join? Can I join? I'm like, sure, you can join. So we built this network of doctors in 48 out of 50 states. I think we're now in 50 states in every specialty. And the specialties are getting better and better because there's so many doctors doing lifestyle medicine, family practitioners that are looking at your genetics, looking at everything about you to make an informed decision about your risk for different cancers and how you screen, and to really very siloed specialists who are really good with say hand surgery and neuropathy, to rheumatologists that are some of the rheumatologists is like a handful of them, and we've got one of the best in the country. And it's to be able to be that expert to solve that problem for you that you've been your gout, for example, that's not under control. So we're very proud of our network. We expand our network. We are exclusively physicians, although we have also doctors of podiatry and optometry, and also psychologists on our platform.
Wow, so that's amazing.
So that's the UBERDOC model. We also, though, do have another version of ourselves that we do patriotic, fit for duty, as well as we service vets and we service first responders and our reservists, and that is probably what I'm most proud of. That we are servicing those people to make sure that they are getting their benefits, that they're assessed properly. And that model is actually with our current doctors. And also that model allows, physician assistants and nurse practitioners to also join us in that effort. So we're very excited about UBERDOC, because we feel like, it's there for patients. We like to think we're the best kept secret, and we want doctors to feel really comfortable pivoting a little bit toward direct pay. I always say I want a seat in your waiting room. Next to your Medicaid, next to your Medicare, next to your Blue Cross, put an UBERDOC seat. Just 1 or 2 a week. It's like a house seat at a Broadway show. It's there for the taking. Some patients you may not fill, but other people will want to use that seat. And my guess is more and more people are going to be demanding that seat.
I think that's an amazing model. And you're right, it was the best kept secret because I had never heard of it until I was on that webinar with you. I'm like,
it takes tens of millions of dollars for people to know about anything. I have to say, at the early stages, we were on a local Fox network, in Boston. And then the platform flooded. It was but we only had 40 doctors at the time. And I'm like, you know what? This is going to work. This is going to work. Yeah. And that was, and like I said, even with, employers, they, again, it's utilizing, UBERDOC just gives your employees the fast pass. They can use their HSAs. It does decrease utilization if it's off the grid, which means insurance brokers don't like to sell it or mention it because just like you said, we're going to make that baby step in Texas where you can put it against your deductible, as long as we know about it, which is okay. So UBERDOC is a perfect service for people in Texas. So, so we get out to the doctors. We want every doctor to join. There should be no barrier to entry for an UBERDOC We are challenged sometimes by consolidation, just because of it becomes complicated. But and some people don't want to give up, don't want to lower the price, don't want to be transparent.
Well, okay, so that's where I was going next. Let's talk about transparency.
Yes.
We have legislated transparency, which is why we had to do that, is ridiculous in the first place. I mean, that should just be a common sense given that you can tell somebody how much something is going to cost, or at least give them a reasonable estimate. That is one of the foundations of what you do, correct?
Our mission is price transparency and access. That's it. That's pretty much it. I like to say that UBERDOC sets the transparency. We don't set the price, although the price has guardrails. It can't be lower than 150 because we're physicians and experts, and it can't be higher than 500. So if you're like a super expert and want to be 1,000, that's not us. We want to make it affordable to the patient and sort of in that Medicare sort of like consultation range. And so that's where it is. But I think it's hard to set the price, but you can set the transparency.
I think that's a really great attitude. Okay, so we talked about this briefly at the beginning, but you are also very passionate about women's health.
Yes.
And why is this important to you, and how can we improve awareness and access to appropriate care? Because it's not happening currently.
So when I first went into practice, so I was a newly minted vascular surgeon, and I was working in a community where I was like the only woman and the youngest by like 20 years. And I was mentored by a woman, a general surgeon in another community. Said, "You're going to go to a breast center." I said, "What do you mean?" He said, "You're just going to go and you're going to see patients. You're going to be Dr. Thursday. Dr. Thursday. So patients, when they get a mammogram, if they need another view, you're going to be there to talk to them and decide what they need, because women really need to make sure that when they get that abnormality, they see a doctor as soon as possible, right? We don't want any delay in that." And I'm like, okay, I'm a vascular surgeon. She said, "And you're going to put that breast hat on so that you can open up your office hours to other patients. Because as a woman surgeon, your entire office hour will be filled with breast patients, right? And your partners are going to take those cool new vascular cases that you've been trained to take." So I'm just going to be completely honest. That's how it all started, was just say, so I put my breast head on, went to a breast clinic, learned and I hadn't, honestly, I'd been operating on aortas, for the last year or so. It was like to do, I had to say, wow. And I sat there with radiologists teaching me. It became that's the only way I've ever done breast, is in that kind of model. And I learned a ton. And then she said, it's going to take you at least a year to learn how to examine a breast. It took 2. Truly, it is something that's important, that's different. But I never, ever gave up like women's health, because then I realized it goes beyond just breast health. It's your vascular health. I was still in a vascular society where they said, women's arteries are too small to operate on. Like somehow or another, like women didn't have heart attacks, women didn't have strokes, right? It was just Mylanta. Right. And so you're like, are you kidding me? Women face the same challenges. They have the same smoking rates now, and their hormones protect them. In other words, women were kind of pushed aside on the vascular side. So they got diagnosed later. And they had their heart attacks later, and they had their strokes later. So I said, okay, every breast has 2 carotids. Every breast has legs attached. So that's how I started. And then I started talking to other people in my community, like the urologists. There's one female urologist. It's like, oh my gosh, the whole concept of like of incontinence, right? Women have so many changes that happen down there after babies and so forth, and there wasn't any real treatment. It was always kind of pushed aside in a practice. It wasn't front and center. It was like, here's all we do is prostates, and oh, by the way, a little bit of this. So as I sort of just my journey as a practicing private practice doctor, I realized, first of all, the impact of women's health beyond just breast health or gynecologic health, right? Beyond that. It was the whole woman's body that needed to be. And to this day, we still have many, many inherent biases. And now I do a lot of venous work. And of course, it's all like, oh, it's women, it's cosmetic. It's like, time out. It's a disease. Everyone's in my womb clinic, men and women equally. It's not a gender-related disease. Vascular is not gender-related. So women's health has been my passion. And breast health, I've always followed that same path. And it's been very it's been sad to me over the past few years how that simple equation of just getting the patient seen, taken care of, has just lengthened into a series of billable events that make that poor woman wait and wait and wait and pay and pay and pay. And I have people now who won't come back for a breast ultrasound because they couldn't afford the last one. And I'm like, but what are they charging you? And then you see the price, you're like, oh my gosh, that's ridiculous. So anyway, so that's my passion with women's health. It comes from the whole body and from just learning from the ground up that it's not that hard to do what we do. We just, but when you see it become, too many steps, it's sad, especially with breast cancer. It's like we've had so many amazing treatments. Like our patients do so much better than they did 10 years ago, even 5 years ago. There's no reason that we can't make this work.
But they still send out that letter that says you had an irregular mammogram, and you open it up in the mail and you're panic. And of course you can't talk to anybody. And we don't even know when we're going to be able to get you in to see you.
My dream is like, I want it all telemedicine. Like you go get your mammogram and there's a tech there and there's a navigator there and like a Dr. Dickerson on a screen.
Yes.
To be able to say, Nancy, I'm worried about this. Let's do a spot right now. Let's figure this out. So, okay, we need to say, and then just navigate the whole thing. I mean, book your mammogram with UBERDOC has been a big dream of mine. Just pay cash, get in, get it done, but get it completely done, right? To beginning to end, right? Not come back tomorrow. Let's come back tomorrow because they say, well, insurance doesn't pay for it unless you come back another day. It's like, oh my gosh. I actually had one woman who had one breast done and had to come back a week later to get the other breast done. I'm like, what? You have two breasts. Because
they're both the same body.
But because it was again, getting back to what we were talking about, some insurance protocol dictating that. And it doesn't do anyone any good because it really, at the end of the day, costs you more. You're not making any more money on that. That's just silly. It's just silly. Yeah. So that's why I absolutely would love to just make it I think mammograms should be on your phone. I think you should carry it away with you the moment you leave. Should not be owned or housed in some type of women come to me with discs. I'm like, I don't have a computer that takes a disc anymore. What do I do with this disc? So I tell them now, can you just take your phone out and take a picture of your mammogram for me? Right? Because I have the record.
Sometimes they won't let you.
I take a picture of mine. I tell my patients just sneak around and take that picture.
Yeah, I like that idea.
Well, if they can't upload it immediately when you leave, into your Dropbox, then, because they say, well, you have to go through Epic, but Epic only shows you the report. It doesn't show you the picture.
Correct.
Right.
Yeah. Very interesting.
So anyways, but with the technology is all there for the taking. It's just that there's a presumption that each one of these pieces of data has value, but really monetary value, but it really doesn't.
and we have to get back to the fact that it's my body. And you talk about data. You shouldn't be able to hold my information about my body hostage.
We talk about women's right to choose. It's like everyone's right to choose. I have a right over my uterus and my breast, and a man has a right over his prostate. That's your body.
Correct.
And that gets back to the 1960s approach to medicine, which the doctor knows what's best for you. That's not where we are now. This is the patient needs to be informed and driven. And I believe everyone, whether you're, very like a graduate student or you have literacy issues, you understand your body the same way. Yeah. And that's been researched many times. So I do think that part of the sadness of our current system is we've forgotten about the patient. Just like you were told, well, it's unfortunate that you had that reaction.
Yeah.
You should have gone home.
I know.
You shouldn't have broken your leg. Yeah, it's like,
well, it was funny because of course being involved in health insurance, I asked a lot of questions when I was at my pre-op, which they weren't a big fan of, by the way. And I asked the question, I said, because they said, well, we'll discharge you, a few hours after your surgery. And I said, well, what happens if I need to spend the night? Because my sister, my father, I have a history in my family. I actually had hip dysplasia, not just arthritis. So I just wanted to ask the question. And she looked at me like I'd sprouted another head. And she said, our goal is to get you out in 23 hours and 59 minutes. Yeah. And I'm like, I didn't really think you needed to tell me that, but
it's almost like you're on a plane and they're Delta saying, our goal is to get you there.
Yes. And so I just found the whole experience so interesting. And actually, I couldn't be happier that I went through it, because it gave me an insight I did not have previously as to things that some of my clients experience. And so I'm actually really grateful that all that happened.
And the funny part is that, so there's a lot of metrics, right? We have all these quality measures. None of them really measure anything. They're measuring that. They're measuring how fast it is that you can, get out, or, nothing, none of the metrics actually reflect outcome or quality.
No, correct.
And because it's really hard to measure those. And I kept thinking, why are we wasting time doing that? Honestly, I would pull the plug on all of this. One of the things that I had hoped with the stroke of a pen that an executive order would come through after price transparency was suspend all incentives. Like if you literally eliminated incentives for an entire year, no more incentives, which meant that you can't submit those quality reports because you're only going to get paid what you're going to get paid. You're not going to have those extra bonuses that you think you're getting. And then it would remove all of the infrastructure built around chasing those incentives. So much of that is just inflation, and it's not necessary. And so one of those 20, that nurse, whoever's telling you to get out in that 59 minutes, that's an incentive, right? That's like, because we're going to somehow get more money if we do that. Imagine if there were no incentive, maybe, and if it were transparent, it is what it is.
I like that. Okay, so we get to move on to the last couple minutes of the show, which are my fun questions. And since the name of the show is Recipe for Success, because I love to cook, and one of the things that I discovered was that every person's successful idea, successful business has one thing that makes them succeed, makes their recipe turn out, makes their business work, makes them successful at whatever it is. So the question is, what's your absolute favorite food in the world, and can you cook it?
Okay, so I can make pastino trigata. Italian and me.
Coming over for that.
I can do that, and that's my go-to when I'm very upset or I need comfort food. I can whip that up in no time at all. I weaned my children. I was weaned on it, and it's a very simple recipe. The key is I do use acine pepe. I don't always use pastina because pastina is too tiny. Is to, when you boil the pastina, you have to strain it and throw it back in very quickly with a lot of water in it, because then you throw the butter and the regatta in. You want that to sort of stay creamy. If you drain it too dry, the pasta sticks.
Yeah, pasta water is critical to any good pasta.
Pasta water is critical, but that pastino trigata, that's my go-to.
Yummy. Okay, so what is the character trait you admire most in other people, and why?
I love courage and conviction. When I see someone who just says it like it is, and I should add kindness. They can't say it like it is in a nasty, like, oh my God, that's terrible.
Sure.
I had a mother that was she always said it. She always spoke the truth. She just felt it was who she was. And I think that, you think about, like, yes, sometimes it's something you may not want to hear. And if you add the kindness to it, but I really do admire people with conviction.
I like that.
I really
do.
So
if I were to turn the mirror on you, what's the character trait in yourself you're most proud of, and why?
Most proud of? I think I'm persistent. I think, I'm a sort of I'm a hopeful person, right? And when things get really tough, I sort of that makes me work more. Like I like puzzles, right? You throw that jigsaw puzzle out there and you start overwhelmed with like one piece out of 1,000, and where is it going to meet the next piece, right? I think that sort of that persistence is what I have. Some people say, oh my God, she just doesn't give up. There's that can be annoying.
Well, I have a term for that. I call it being pleasantly persistent, because I don't think you can get where you need to go if you are not pleasantly persistent.
And actually somebody said that to me not too long ago about harping on the breast center concept. Oh my God, don't you ever get off that? Don't you ever change your mind? I said, no, I won't. Because it's the right way to do it.
It is. I love it. Okay. So from a doctor standpoint, putting your doctor hat back on, what's the one question every patient should ask their doctor?
well, snarky, I could say, do you know what with that prescription you just wrote for me? Do you know how much it's going to cost me?
They should ask that question.
They should ask that question. I always tell my patients, if they don't understand, they need to ask, right? I mean, they need to ask. I mean, there is, and again, the snarky part of me is, are you ordering that test because I need it or because it's for insurance, right? Like, they need to ask those questions, I mean, and I find that patients sometimes, most of the time, if they understand, it's okay. It's like, some people just don't want to engage. They're like, yeah, I trust you, doctor, do whatever. But then other patients, you could see that they can't get the question out.
Yeah.
Right. And sometimes I tell them, go home, think about it, let me know, because sometimes you just have to empower them to ask when they don't, tell you when they don't understand.
Yeah, I agree. Okay, so here's a fun one. What's your secret talent or something people would be surprised to learn about you?
Oh, surprised to learn. Well, I am a very good squash player. I like squash. I'm a tennis racket. I'm a tennis player and a squash player. So, so I think that, but I love karaoke.
Oh, that is a good one.
I love karaoke. I had a 60th birthday recently that was a surprise party. My husband had the karaoke there. And I do have a go-to song, it's Winner Takes It All from ABBA, of course.
Of course.
It's like, but yeah, I love karaoke. I think I'm really good at it too. I don't know.
Well, we need to get you with the Green Imaging ladies because they're big karaoke fans too. Somehow I always end up with her, but I'm just the backup person that does this because I can't sing for anything. I'm the encourager. I'm like, yeah, you can do it. Oh, that's funny.
Probably really good at it. I don't know. I just everyone always claps when I do it, so I don't know.
And you must be good. I love it. Okay, last question. Who's the one person, famous or not famous, dead or alive, that you would most love to be able to sit down, have a cup of coffee, and a conversation with?
Let's see, dead or alive, huh?
Yep.
And I can't say Jesus because
you can.
No. You know what? Oh gosh, I think that I would love to have a real conversation, like take the gloves off conversation with Michelle Obama.
Yeah.
Like an honest conversation, like you got to peel away all the, because I'm criticizing her husband, her surname is now attached to the disaster we have in healthcare. And I don't think that was intended, but I really would kind of, she's somebody that I think is super smart. And if you peeled away all the layers, what story could she tell?
She would be amazing to have that kind of conversation with. Okay, well, this has been so much fun. Now, if people want to use UBERDOC, they're like, oh, that sounds amazing. How do I do it? How does somebody access UBERDOC?
So if you're in, you just go to the site, you put in your zip code, and then scroll down and find a specialty you might be looking for. And then the doctor list pops up, and it's by proximity and availability. So like the doctor that's closest to you, I think, pops up first, and then the doctor who's next available appointment. So that's how it works. It's really that simple. If you don't find what you're looking for, you can actually contact us and say, hey, I need a gastroenterologist in, Austin, Texas, and you don't have one. We are able to then find one for you because that's kind of what we're good at. We like to go after people. We love it when patients tell us, this is a need in our community. Can you fill that need? Because it's fun for us to go to the doctors and say, hey, there's a bunch of people out there willing to pay cash to see you. Just saying. Yeah. Would you like to be an UBERDOC? It's hard not to get an UBERDOC on the platform. So that's how. And we're very connected with our patients. We like to hear from you. We like to have you tell us, what you need.
That's perfect. And of course, I'm a researcher. I always scour everybody's website before they ever come on. So I went on to UBERDOC. I did exactly what you described. It was super easy. It's not confusing. It's very, very user friendly. So I think you've done an amazing job with it.
And on the doctor side, it's even easier. We literally did our user X at the level of a fourth grader. I didn't feel like when patients are worried that they needed to we need a piece of 1,000 pieces of information from you. We take no information. We just take your chief complaint, like my right thumb hurts. That's and on the doctor side, when you request an appointment, the doctor gets a ping and says, would you like to see this woman who has her right thumb hurts? And it's like, well, I'm a psychiatrist, probably not the right person. You can say no, but if it's like, yeah, I'm a hand surgeon, all they have to do is emoji thumbs up. It's like, we really make it easy.
Yeah.
And they get,
awesome.
the patient gets emailed, date, time of appointment, all HIPAA protected, doctor gets paid, patient puts $50 down for that appointment. So everybody's happy. And if the doctor has to cancel, it's all refunded.
That's amazing. Well, thank you so much for your time today, Paula. This has been a lot of fun. And I hope that anybody listening or re-listening to this checks out UBERDOC. It is a fabulous service. And be sure to tell your friends and family, because it is something that is very much needed. So thanks again for joining.
Oh, thank you, Nancy.
Bye-bye.